So first we have Selena Thomas, who is Clinical Co-ordinator and Senior Clinician, St George Community Mental Health. Selena is a social worker with extensive experience in mental health, ranging from clinical mental health outreach to homeless people through St Vincent's Hospital, an incredibly complex and challenging area, to her current role as Acting Team Leader for St George Community Mental Health. She has also provided mental health interventions and program development in Indigenous communities in remote Australia and with refugees in Nauru. She is passionate about mental health service provision, particularly around appropriate interventions for population groups who are often overlooked by mainstream systems. And both Selena and our next speaker are going to talk about some of the implementation issues and some of the aspirations for this framework. Thank you.
Hi, thank you. So I'll be speaking just briefly around why this is important to our service at St George Mental Health. And then I'm going to have to duck out because I have a meeting over at the hospital right after. But then Billie will be talking a bit more around, I guess, the practical implementations and how that looks at St George. So I guess I just wanted to start by reflecting on a gentleman that I've worked with, which kind of underpins why I do think this is really important. When I worked on the homeless outreach team providing mental health services to rough sleepers, I started working with a gentleman in his late 20s who'd been homeless for a number of years. He was banned from nearly every homeless accommodation service in Sydney, had a lot of restrictions around his access to drop-in centres because of his behaviour, outbursts, and things that services just didn't feel that they could manage. He was also well known to nearly every emergency department in Sydney, had a presentation at least once a week, so it was well known to a lot of health providers. When we looked through his health records, we could see that he had spent time as an inpatient, that he had bounced between various mental health services. There were occasional references to cognitive capacity, but no formal assessments had been done, no research into his history, no questions were asked about whether there was more than mental health going on. We were quite lucky to be able to track down some childhood records purely through Aboriginal community networks, nothing to do with the health system, and were able to prove that he had had a lifelong intellectual disability. Because of this, we were able to put the appropriate supports in place, got him his own accommodation, and wraparound support so that he was now living independently with the services that he needed. And it didn't mean that everything was now perfect and lovely, but his quality of life improved significantly. He originally became homeless, we found, after his supported living broke down, which he was placed in after his foster care arrangement broke down. And so one has to question whether the collaboration that we've talked about and carer support had actually all happened earlier, whether this extensive period of homelessness could have been avoided altogether. It also, for me, raises the question around whether improving knowledge around intellectual disability for service providers in both the mental health sector and the general health sector could have actually asked these questions about intellectual disability and sensed that something else was going on if appropriate training was available. So I guess that damage to his well-being, to his physical health and his relationship with service providers, all of that damage would potentially have been avoided altogether. So that little snapshot, I guess, is one thing that resonates with me about why this is so important. So I guess on a more practical level for St George, South East and Sydney mental health service at St George, we really value the recovery approach, which is the belief that every individual living with mental illness has the capacity to recover, and that means to lead a life that is meaningful to you. And we also work from a strengths model that every individual has strengths to achieve the goals that, again, are meaningful to them. So they're things that we implement with our consumers on a daily basis. What that means for people living with intellectual disability is that it's imperative to make sure that we're providing that same service. So it does mean that we do need to look at changing our strength assessment tools, changing the ways that we identify goals, and perhaps being more creative with the way that we do that. Generally, that's something that we do with an individual, but obviously working with people with mental health and intellectual disability, we do need to be more creative around the amount of time that takes, but also identifying the friends and family who may be able to educate us about this person's interests, goals, strengths, when that individual is perhaps not able to articulate it themselves, the people who know them best are the people that know what's important to them. From a service implementation perspective, we've previously implemented training and frameworks to meet the needs of specific consumer groups and learn strategies and approaches that best meet their needs. This has included areas such as personality disorders, as well as working with ATSI and CALD communities, for examples. We believe that it is important for our clinicians to have that specific training and education to meet the unique needs and experiences of individuals that we work with, and ensure that the time and resources are made available to our staff to undertake this. The IDMH core competencies is similar to this. People living with IDMH face identified challenges in finding and utilising appropriate services, often a shortage of specialised services and lengthy wait lists. It's acknowledged that within the mental health sector, we do have limited staff with the appropriate skills and knowledge to provide best practice care for this client group. And at the same time, referrals for people living with IDMH at our service are quite significantly increasing. So I guess something that's important for our service is we don't want to be part of that wait list and the blockages that people are finding. So we are introducing the core competencies at our service through in-services training and support from management and senior staff. We do believe it's crucial for this to be implemented. I think Billie will talk a bit more now around what that looks like for us and give some kind of practice examples in a case study. So I'll hand over to her now.
And I'll just introduce our last speaker, Ms. Billie Dong, who's Senior Occupational Therapist at St George Community Mental Health. Billie is an experienced occupational therapist who chose to specialise in the mental health area after seeing the importance of rehabilitation and occupational therapy for consumers of mental health services. After working in mental health rehabilitation, she's recently commenced as a senior clinician for St George Community Mental Health. She works with consumers with diverse and complex needs and supports other clinicians with her experience. Billie values the ability to provide improved quality of life to consumers and finding creative ways to meet consumers' individual goals. Thank you, Billie.
Hello, hi, thanks for the introduction. Thanks for inviting me today to speak from a clinician's point of view on aspirations for implementing the core competency framework. As discussed by previous speakers, mental health staff regularly meet and assess people with dual diagnosis of intellectual disability and mental health. So important sections that stood out to me from the manual include the top 10 attributes, which I think for staff who even have occasional contact with a person with IDMH can refer to in the manual. And for more experienced staff who actively work with IDMH consumers in assessment of their knowledge gaps and challenges they are facing, will assist in identifying additional competencies to focus on in their training. So I'd like just to spend a bit of time talk about the top 10 attributes and how clinician in mental health can work on these. So number 1, prepare. So it's really important to prepare as a clinician in identifying the consumer's strengths and speak with the client's family and carers, speak with supported network and previous services who had worked with the consumer to find out what's worked well and the support needs still required. Adjust communication. Some of the things that a mental health clinician can do include adjusting content, the language, and providing written information. Simple things like the font size can really help someone with mental health and intellectual disability to really understand the communication and understand what's being communicated. Using a whiteboard, for example, to provide visual information, drawing things on the whiteboard, and engaging the person support network to communicate the information as well, so including family and carers in the meetings with the consumer. Number 3, engage support networks. Support networks include private and public specialists, GPs, family and carers, and any disability support services. Number 4, facilitate supported decision making. So allocate longer time to meet with the client and explain the treatment decisions and plans, and also again including family and carers in discussions and making sure that family and carers are also part of the treatment plan and understand what is being discussed. Making information accessible, so using visual and verbal information such as picture cards, Compex, mood cards as well. So providing written information in larger fonts and using simple language and providing the information. Know what skill sets are available. Ensure community mental health service understands service approaches from the disability sectors and strategies to ensure collaborative work. Identifying skill gaps and creating partnerships to organise in-service and trainings required. So it's really important to create partnerships with disability sectors, from the mental health perspective, and organising in-services and trainings from both sectors. Number 7, collaborate across agencies, identifying most appropriate services in the area and build partnerships to complement each other and meet the needs of each consumer. Effective communication to minimise client and family members, and to minimise client and family members having to repeat this history. An example of this is to have joint assessments and providing timely responses. So seek support. Skills audit, identifying the go-to person in the mental health service with increased intellectual disability knowledge, and ensuring that staff feels comfortable to ask for assistance when their skills are inefficient to manage, when they feel that their skills are inefficient to manage the client and the family. Learn and integrate knowledge into practice, so participate in competency development trainings, study groups, journal clubs and services, and organising group supervisions in the community centre. And number 10 is quite similar to the previous point of what I've mentioned. So participate in supervision and discuss, reflect on why certain interventions had worked well and other components to improve on. So I'd just like to mention that staff culture and values are also really important in implementing the framework. An example of this in St George include creating a culture where knowledge of IDMH is valued and training time is prioritised for this area of skill development. Forming part of professional development goals and encouraging staff to really think about how they can include this in the professional development goals. Ensuring that consumers with IDMH are discussed in case reviews with experienced clinicians present to increase the identification of gaps and support the learning of clinicians new to the field. St George has a strong culture of training and learning opportunities. By increasing the discussion and knowledge around intellectual disability in the mental health sector, I believe this will increase staff interest and external intellectual disability training and skills development. I would just like to conclude my presentation with a case study. So this is a client of mine that I've been working with. He's a 39-year-old man with schizophrenia and intellectual disability. He comes from an Eastern European family. He lives at home with his mother and other siblings. The consumer and the brother both have intellectual disability. I've got to add into the slideshow about the consumer's interests and hobbies. He really enjoys music and sports. And some of the sort of the challenges that we sort of face with this consumer include his medication, and he's currently managed under a community treatment order with a depot injection. The consumer is quite resistant to the CTO injections as he did not feel like he was being heard by the doctor. Some of the interventions that the team in St George Mental Health had provided include to discuss with the consumer and the family about a transfer of doctor based on who the consumer would feel more comfortable to work with based on the communication style provided by the different doctors. And we facilitated supported decision making by working with the client and the family in meetings with the doctor to negotiate a trial of oral medication for this consumer, as the depot injection was causing a lot of distress to him. We provided the client and the family a simple daily checklist to mark compliance once all members agreed on a trial of oral medication for him. Other interventions we provided with this consumer include creating partnerships with other disability support services such as Uniting Ability Link to support the client and the family with respite care and to link with social activities. I've mentioned before that the consumer really enjoys music, so we're in the process of linking him up with a service called Gig Buddies, which it's a volunteer service which takes people with disability out to different concerts and social events. So we've referred the client to that, and yeah, hopefully they can go out with a volunteer to different concerts. Strong communication between numerous internal and external services and family supports. We've held case conferences with all stakeholders to discuss strategies to support the client living in the community, and yeah, just providing the client with continued reassurance and making sure that he understands the treatment plan and that everything is communicated effectively with the consumer and his family. Yeah, and I think support to the family is also very important. From mental health, we support the family with structured, explaining the importance of a structured routine and consistency for this consumer. The requirement is not just on the consumer to maintain appointments. The clinician is also required to be on time and hold the same expectations as the consumer with appointments. This reduces the confusion for the consumer and stress on the family. And psychoeducation for family around mental health and intellectual disability, particularly around COLD family, engaging supports for carer is very challenging for people from other backgrounds. So lastly, we've also provided education to other areas of the hospital, such as emergency departments, around the consumer's behaviours and presentations, and this has resulted in reduced hospitalisation for this consumer.